السلام عليكم جميعا. اسمي أحمد حواسلي. يسعدني ويشرفني أن أكون بينكم اليوم كمحاضر متطوع في طب الأسنان المباشر. أود أن أشكر دكتور مازن دوماني على تنظيم وإشرافه على طب الأسنان المباشر، كما أود أن أشكر باقي زملائي الدكاترة المحاضرين المتطوعين في الفريق التطوعي. Good evening everyone. My name is Ahmed Hawasli. I am oral surgeon and I am periodontist. I am working currently in Virginia, and today my lecture will be on maxillary sinus lift, different approaches. This is just a quick introduction of myself. I graduated from University of Maryland. I did also my master program. This is my paper. If anybody is interested, I can definitely send you the paper. I am also active on Dental XP. I posted many different cases for education papers. I'm also active on social media on Facebook, where I posted also different clinical cases for educational purpose. So, as introduction to my lecture today, we know that the first sinus elevation was posted in 1977 by Tatum. The classic procedure for this augmentation entails the preparation of a trapdoor to elevate the Schneider membrane in the lateral sinus wall, and then the space created beneath the lifted sinus membrane is grafted. Then summer in 1994 came with a less invasive procedure for sinus wall elevation and with immediate implant placement, in which the membrane is elevated using the osteotome from the Crestal approach without the preparation of the lateral window. Now let's see when we can do the lateral sinus lift and when we can do the Crestal sinus lift. There is a paper for Jensen in 1998, and they have classification regarding the sinus lift depends on the residual alveolar bone height. So class A, when we have the remaining alveolar bone height 10 mm, it's a classic implant procedure, doesn't need any sinus lift. And then we have a class B, when we have residual alveolar bone between 7 and 9 mm, and the osteotome technique should be applied in combination with immediate implant placement. And then we have a class C, when we have between 4 to 6 mm alveolar bone height, a lateral approach involving a grafting material with immediate or delayed implant placement. And then we have the last classification, which is a class D, when we have 1 to 3 mm alveolar bone height, a lateral approach involving a bone grafting material and delayed implant placement is recommended. طبعا هم مثل ما احنا شايفين في عنا classification حتى تبين لنا امتى ممكن نعمل اللاترال ابروش وممكن نعمل الكريستال ابروش. هلا بوجود الطرق الحديثه والتقنيات الحديثه طبعا صار فينا نعمل نحن الكريستال ابروش لما يكون عندنا 5 ملي 4 ملي ممكن نعمل كريستال ابروش، وفينا نعمل حتى immediate implant placement مع lateral approach لما يكون عندنا 4 to 5 mm. So I will start talking about the lateral window sinus lift, and the first part I want to mention is the bleeding. So according to the anatomy of the posterior superior alveolar artery, we have the intraosseous branches that comes from the posterior superior alveolar artery. And this is small artery that run into the lateral wall of the sinus. And here you can see on the clinical photo taken from the internet, we see the lateral window of the sinus. And then also we can see here the intraosseous branches of the posterior superior artery. It's very important to identify the structure. We can identify the structure before the surgery through the cone beam. Sometimes we can identify on the x-ray. And also we need to identify the structure during the surgery in order to avoid the bleeding issue. According to Ilian study in 2005, the intraosseous artery has the potential to cause a bleeding complication in 20% of normally positioned lateral window osteotomy. The average height from the alveolar crest is 16.4 mm, and this is very important here. So we don't want to have our window is too high from the crest. Also, according to Valenti in 2015, he showed that the diameter of this artery is about 1 mm, but sometimes it becomes 1 or 2 mm. and when we have more than 1 millimeter, this is, if we hit this artery, we end up with severe bleeding. So we want to avoid that. Another complication that I want to mention is the perforation of the membrane during the surgery. We have classification for the perforation according to Vlasis and Fogazzato in 1999. So here, as we can see, we have class 1. The perforation is located on the superior border of the window, on the corner part. And then we have class 2 in the middle superior part. Class 3 on the inferior border of the window, on the mesial and distal side. And class 4 in the middle inferior border, like here. And then we have 5, which is in the middle of the sinus of the window. So here, according to the study, they showed that the class 1 and class 2 perforation are the most likely repaired, while class 4 is the most difficult to manage. So if we have perforation on the superior border, it is easier to manage than if we have perforation on the inferior border. And in this slide, I will show you the main two techniques regarding external sinus lift. So the first one is called wall-off technique. As we can see here, we use a small tufine burr, or we can use a piezo or small round burr to cut around a bony island from the lateral wall. And then we start to drill at desired location and proceed until we see the shadow of the sinus membrane. Then we separate and lift the bony island up from the neighboring wall with a small curette, and then the bone island can be repositioned back in its original position after the bone augmentation. However, we mainly keep the island bone attached to the membrane, and we lift up the membrane with attached bone without removing the bone from the center of the window. The second technique is called thin out technique, and here we use a large desk bear, as we can see on this picture, or we can use a large diamond bear or piezo, and by this technique we thin out the lateral wall. We shave out completely the bone until we see the Schneider membrane, and we use this bear at 45 degrees until we reach the Schneider membrane. Personally, I like the thin out technique because I like to see the membrane. I like to see completely the window. It gives me better visibility and easier to manipulate the sinus membrane elevation, because when we have a small bone island in the center, it's hard to get access with the instrument and separate the membrane and elevate membrane. It's sometimes, of course, we need to shave down the island bone in order to get better accessibility with our hand instrument to do the sinus elevation. So I like personally to approach with a thin out technique. And now I will show you a small video, one of my clinical cases of the external sinus lift. هلا حنشوف a small video للexternal sinus lift. مثل ما أنا شايفين احنا هون I start with a small tufine burr. I use this burr just to locate my window. We mainly use this burr with wall-off technique, but I just use it to locate my window. ممكن مثل ما شايفين هلا هون الويندو outline، وعندنا inferior border هون مثل ما حنشوف the inferior border should be about 5 millimeter, at least 5 millimeters superior from the alveolar crest. يعني احنا عندنا inferior border للويندو لازم يكون حوالي 5 ملم أعلى من crest of the bone. لازم يكون على الأقل 3 ملم from the sinus floor حتى نحسن use الكيوريت ونعمل elevation للممبرين، لأنه إذا حطينا نحن inferior border على sinus floor we will end up with perforation، ما حيصير معنا sinus lift. وطبعا هون مثل ما أنا شايفين the superior border of the window is about 12 to 13 millimeter from the alveolar crest. يعني احنا أقل من ال 16 ملم اللي حكينا عنها بالأول محاضرة. هلا الخطأ الأولي بهالحالة هي مثل ما أنا شايفين الفلاب عندي صغيرة ف I have difficulty in retracting the flap. What I like to do is to extend the releasing incision more mesially. We do like we call it subgingival or submarginal incision in this way, and then I drop the vertical releasing incision. So I preserve the papilla and the gingival margin of the adjacent teeth. So I prevent any further recession after the surgery. هلا حتشوفوا حستخدم what we call the desk burr. It's large diamond burr and it's safe burr actually. It doesn't perforate the membrane. We use it at 45 degree. بنستخدمها يعني بنعمل stroke mesially distally until we reach the Schneider membrane. مثل ما أنا شايفين it's a large diamond burr. We call it like a desk burr. It's very common system. مثل ما شايفين 45 degree stroke. هون بلشنا نشوف البلد vessels الموجودة على sinus membrane. وشوي شوي هلا عم بلش نشوف blood supply and we thin out the lateral wall. هون بلش ينكشف معنا أكثر الغشاء. We can see here now the membrane. طبعا the beauty of this burr is it gives you smooth round border. So it's minimize the chance of the perforation when you use the hand instrumentation. It's very important to have a smooth round border. يعني حتى يكون عندنا الحواف الويندو تكون smooth and round. هون مثل ما ملاحظين لسه في طبقة من العظم مغطي الغشاء. فهلا برد بستخدم البير مرة تانية to thin out this remaining bone layer. وفينا نعمل extension للويندو by this burr. هون مثل ما ملاحظين I'm extending my window. So actually I don't like to have a very large window and not also a small window. يعني لازم يكون متوسط diameter الويندو يكون حوالي 7 by 7 millimeter. هون مثل ما شايفين we started using special tool, special sinus curate. The convex part should be toward the membrane, the concave part toward the bone, and always resting on the bone. And personally, I like to start with the anterior, superior border, distal border, and lastly the inferior border. شايفين هلا الطبقة رقيقة من العظم هون. And when we do the sinus elevation, we do it gradually. We don't elevate the membrane at one point too much because we will end up with perforation. So I'm resting on the bone and very gently I'm releasing the membrane attachment, and then I go gradually deeply until I reach the medial wall and the anterior wall. So here we can see now we start lifting the membrane, releasing the membrane from the lateral wall, and we can see the transparency of the lateral wall of the sinus. Now I'm doing the floor of the sinus, resting on the bone and gradually releasing the membrane. لو ببين معنا الميمبرين كيف عم بندفش. هلا في حال إذا صار معنا أي perforation نحن ساعتها بدنا نعمل extension للويندو beyond the perforation site. يعني لو كان عندي perforation هون أو هون أو هلا تحت حيكون very صعب مثل ما حكينا، بس إذا كان عندي perforation فوق بعمل extension أنا للويندو beyond the perforation وبكمل ال elevation beyond the perforation. فلما بعمل أنا elevation beyond the perforation the sinus membrane itself is gonna fold on itself, so it's gonna close the perforation. طبعا بنستخدم هون collagen membrane also to cover the perforation. هلا حتشوفوا بلشنا نشوف حركة الغشاء مع تنفس البيشنت، مع تنفس المريض، which is a good sign. It means that there is no perforation on the sinus membrane when you see that. هلا هون elevating the membrane until I reach the medial wall and also the anterior wall of the sinus. It's very important to reach the medial wall. وهلا مثل ما ملاحظين حركة الغشاء. And this is good sign of intact membrane. وهلا الخطوة الثانية حتكون ال osteotomy preparation for implant placement. هون بلشنا بال preparation for the osteotomy. طبعا دائما حنفضل لما نعمل image implant with external sinus lift إنه نخلي ال osteotomy diameter is smaller than the implant diameter, like about half millimeter, to get good stability. On the parallel pin, just to make sure that I have good direction and good position. On we are extending the osteotomy. هون هلا مثل ما شايفين بلشنا نحط البون graft. Here I was using the allograft. It's FDBA allograft using large particle size. The particle size here 1 millimeter. طبعا there are also small particle size FDBA. It comes between 0.3 to 0.8. We don't use such size with sinus lift because of the high rate turnover. يعني هون احنا بنستخدم البارتيكل سايز تكون كبيرة لأنه ما بتمتص بشكل سريع مثل البارتيكل الصغيرة. نعمل packing للبون graft gradually incrementally. بنحاول طبعا إنه make sure إنه البون graft packed medially and anteriorly. هلا لازم هو الحقيقة ناخد X-ray قبل ما نحط الزرعة حتى make sure that we have good sinus lift with the bone graft. أنا هون في خطأ بالكيس ما عملت الإكس-راي. والأذر تيب إنه يفضل إنه نحط نحن بون جرافت ضمن الأوستيوتومي قبل ما نحط الزرعة وبندفش البون جرافت بالزرعة. كمان هون ما حطيت البون جرافت. لما نحط البون جرافت بالأوستيوتومي وبندفش البون جرافت بالزرعة we want to make sure that the implant will be surrounded by bone graft. هلا مثل ما شايفين we have high torque with the implant placement. We achieved good primary stability. وبعدين طبعا بنحط bone graft on the lateral aspect of the implant. We continue to pack bone graft as we see here. وبعد ما ننتهي من البون جرافتينج لازم نغطي الويندو بممbrane. It's very important to cover our window with membrane to isolate the bone graft from any soft tissue invading. لازم نحن نعزل الويندو والبون جرافت تبعنا بممبرين حتى ما نخلي السوفت تيشيو تبع الفلاب يدخل ضمن الجيب، وبالتالي بصير في عنا فشل. هون مثل ما شايفين حطينا الكولاجين ممبرين and here after we trim the membrane فضل أنا extend the membrane to the palatal flap و tag the membrane under the palatal flap فبتعطينا better stability للممبرين. وبعدين بنرجع الشريحة وبنخيط بشكل طبيعي. طبعا we want to make sure to have a primary closure. هون هلا مثل ما شايفين بالإكس-راي we have a dome-shaped radio opacity around the implant which gives a good sign for the sinus elevation. هلا المشكلة هون مثل نحن ما شايفينها على الميزيال aspect it's not completely radio opaque. نحن بنحب نشوف إن البون graft reaching the anterior wall on the X-ray. فهاي الخطأ نحن بالحالة إنه ما عملنا X-ray قبل ما نحط الزرعة وما عملت packing للبون graft ضمن الأوسيتومي قبل ما أحط الزرعة. So this is what we see now. هلا رح نشوف حالة تانية لأكسنال sinus lift. مثل ما شايفين we have decayed remaining root على premolar, badly decayed molar. فالتريتمنت بلان كانت إنه نعمل extraction للpremolars والmolar ونعمل immediate implant placement مع الاكسترنال sinus lift. مثل ما شايفين هون بالصورة الثانية عملنا الاكستراكشن وهون الاوتلاين للويندو، والصورة الثالثة تحت هون عم نشوف كيف عملنا الساينس ليفت، وبعدين حطينا الزراعات هون الاكس راي بتوضح لي هلا مثل ما شايفين الدوم شيب راديو اوبيك. فلاحظين هلا هون البون جرافت is reaching now الانتيريور wall للساينس. This is what we like to see on the x-ray لأنه بدي أنا good blood supply من الانتيريور wall. فلما احنا نوصل البون جرافت على الانتيريور wall والميدل wall we assure that we will get good blood supply from all the wall of the sinus. هاي الإكس-راي أخذناها بعد 6 شهور. بنلاحظ how the bone graft reaching the medial wall and we achieve a good sinus elevation with good augmentation. وهي الإكس-راي اتاخدت بعد وضع الزرعة بعد ما عملنا الستيج 2. بنلاحظ الزرعة محاطة بشكل كامل بالعظم. وهي الإكس-راي was taken 1 year after restoration. Completely the implant is surrounded by the bone and we can see the stability of the bone level. وهي الفاينل restoration after 1 year of the implant placement. هلا خلينا نحكي شوي عن الكريستال ساينس ليفت. مثل ما بنعرف في تقنيات متعددة بالنسبة للكريستال ساينس ليفت. في عنا الأوسيتوم اللي هي الأول ما طلع فيها بسمر عمل الأوسيتوم. وفي عنا كمان هلا سيستم فيه لهم سنابل إلها مثل ستوبر so it's safe. It's called hammerless sinus lift kit. وفي عنا الهيدروليك sinus lift بنستخدم البريشر مع الووتر to elevate the sinus lift طبعا saline. وفي عنا البالون technique also for the crystal sinus lift. وآخر شيء في عنا الأوسيو densification sinus lift اللي هي الفيرزا بير. هذا نظام جديد في الكريستال ساينس ليفت. هلا في systematic review لديل فابرو بال 2011 it shows that the transalveolar sinus augmentation technique, the prognosis can be more favorable when the alveolar bone height is at least 5 mm. يعني لازم يكون عندنا at least 5 mm حتى نحسن نعمل predictable vertical sinus lift. طبعا بالمقارنة lateral sinus lift the osteotome procedure are less invasive and the operation time is reduced and the postoperative discomfort is minimized. However, the main disadvantage of the osteotome technique is uncertainty of possible perforation of the sinus floor. لأنه هذا يعتبر blindness technique، ما بنشوف إحنا الساينس ليفت بالكريستال approach، يعني بنعتمد على مبدأ الحس. ف في صدية لهم مثل ما شايفين إحنا بتقلك إنه the sinus floor may be elevated up to 5 mm without perforating the sinus membrane. يعني إنه ترفع الساينس ليفت لحد ال 5 متر it's safe without perforating the sinus membrane بالcrystal approach. This is one of my crystal sinus lift case. ملاحظ هون عم نستخدم السيستم اللي بيجي مع الستوبر. فنحن هاي الستوبر بتمنع إنه البير تدخل أكتر into the sinus، وبالتالي we minimize the possibility of the perforation or of the membrane. حتى في عندك الهاند انسترومنت اللي هي الكوندنسر اللي مستخدمة ب condensing the bone graft إلى stopper كمان، وبالتالي تمنع إنه ندخل زيادة ضمن الساينس أو نعمل perforation للساينس. And this is the X-ray. As we can see, we have about 6.5 to 7 millimeter of your bone height. وطبعا بهذا السيستم نحن هون وقفنا عند الساينس الفلور مثل ما شايفين. And this is the X-ray after the implant placement. وملاحظ كيف implant is totally surrounded by the bone graft. This is clinical photo at the implant placement, and this is the X-ray 6 months post-operative. نلاحظ إنه الزرعة لساتها محاطة بالطعم العظمي. هلا بالنسبة للأوسو-densification sinus lift. This is a new system. في دكتور سوري اسمه دكتور صلاح هويس بأمريكا. طبعا نحن نفتخر فيه كثيرا، هو يلي اخترع هذا السيستم. The Densification technology is based on novel biomechanical bone preparation technique called osteodensification. It's unlike the traditional dental drilling technique, when a densifier is rotated at high speed in reverse non-cutting direction with a steady external irrigation. Bone tissue bulk is preserved and seamlessly compacted and autografted in outwardly expanding direction. فهالسنابل هي بتدور بعكس عقارب الساعة at high speed، ومثل ما شايفين احنا الشفرات تبعها صايرة بشكل طولي وليس بشكل عرضي. فبتعمل لي هي two mechanism، بتعمل condensing للبون وبتعمل also spreading للautografts. يعني هي بتعمل تقشط شوي من الطعم، أو بتقشط شوي من العظم، وبتعمل spreading للبون condensing للبون laterally and apically. هي بيسموها tornado in the bottle، يعني مثل عاصفة ضمن الزجاجة يعني. ومثل ما شايفين بتعمل لي هالو أو بتعمل لي مثل راديو أو بايك لاين مثل حوالين الجذر السن الطبيعي، بيسموها اللامونادورا compact bone. فهي بتعطينا نفس المنظر. فالbiomechanical and histology validation study has concluded. ومثل ما شايفين هنا حاطين ossification create a densification crust around the preparation site by compacting and autografting a bone along the entire depth of the osteotomy. فهي بهالعملية هي كمان لما يكون العظم طري بتحول لعظم قاسي، بصير في عندي insertion torque عالي للإمبلانت، وكمان ال contact between the bone and the implant is higher. يعني بتزود من ال contact مع ال implant. هي كمان مأخوذة من الويب سايت للفيرسا. فبنلاحظ هون الخطوات. طبعا في عنده initial drill، وبعدين expanding gradually بالدنسابير. ملاحظ كيف هلا هون صار في عنا انغماس، او صار في عنا sinus lift بالتيب للبير، ومنوسع gradually. طبعا نحن اذا عنا مثلا مثل ما شايفين هون، اذا residual alveolar height is less than 7 mm، ممكن نحط bone graft ونعمل كوندنسك للبون جرافت بالسيستم هاد، بس بنحطه على اللو سبيد. بنحطه counter clockwise with a speed between 200 ل 600. هلا هي كمان احد الحالات اللي عملتها انا بالدنسابير بالكريستال ساينس ليفت. هي كانت عبارة عن extraction and immediate implant on molar و crystal sinus lift in both sides, and first molar was second molar. طبعا this is molar is unrestorable. It has a decay and broken down at the gingival margin, so we end up with the extraction of this molar and place immediate implant with a crystal sinus lift, and place another implant also on additional site with a crystal sinus lift. مثل ما ملاحظين هلا هون احنا بالدنسابير لما نستخدمها بتعمل لي اوتو جرافتنج للساينس فلور، يعني هي بتدفش العظم نفسه apically into the sinus. وهون بالصورة هون بنشوف الcompacting للبون جرافت ضمن الاوستيوتومي. Then this is the X-ray. هون the implant placement. طبعا عملنا bone grafting للbuccal space, and also عملنا ridge augmentation buccally to increase the bone width around the implant, وcovered with a membrane, وعملنا suture للفلاب. طبعا هون it's hard to get primary closure because it was immediate implant at molar site. And this is when we did the stage 2. This is a photo. طبعا عملت أنا شوية alveoplasty فمشان هيك ملاحظ البليدنج. And this is the X-ray after the stage 2. فبنلاحظ نحن هون ال apical part of the implant is covered by bone graft. وهي حالة تانية كمان عندي ال average bone height حوالي 6 ملم. استخدمنا ال Densification in the reverse rotation at high speed. وملاحظ اللي هون بالكلينيكال فوتو ملاحظ ال floor of the sinus، وملاحظ ال whitish appearance of the osteotomy. طبعا هذا ال whitish appearance هو بسبب انه البودرة العظم compacted along the osteotomy، فبتعطينا هالمظهرات. طبعا حيصير عنا blood perfusion like after a minute, so it's not scary to see الوايت color هذا بالاوستيوتومي. حيصير في عنا blood vessels coming after we place the implants. هون بنلاحظ الصورة أثناء الإمبلانت بليسمنت. طبعا حطينا احنا also bone graft ضمن الأوستيوتومي، ودفشنا البون جرافت بالزرعة. بنلاحظ الزرعة كيف محاطة بالبون جرافت مثل ما ملاحظين على الإكس راي. and this is after the suture. وهي حالة تانية كمان عملناها crystal sinus lift also densification. Patient came 2 months after we extracted number 2, the second molar, and as we can see on the X-ray, we have incomplete healed side. So we used a Densification to do crystal sinus lift to replace the implant, and you can see here this is 6 months after the implant placement. We have a good healthy keratinized tissue, and the implant is completely surrounded by the alveolar bone. Now, can we do crystal sinus lift when we have less than 4 mm alveolar bone height? let's push the envelope. Let's see if we can do Crestal sinus lift when we have less than 4 mm average bone height. هلا في study, it's case series study by Soradi and Dr. Wang بال 2012. عملوا 14 maxillary sinus lift and they have less than 1 mm average bone height. يعني المرضى اللي عملوا عليهم كان عندهم أقل من 1 ملم remaining average bone height. طبعا احنا أقل من 1 ملم لازم نعمل external sinus lift. فهنا شو عملوا هون؟ عملوا الويندو نفسها using piezo، بس بدل ما يعملوها على lateral aspect عملوها from the crestal bone. So a window is open from the ridge crest instead of the lateral wall, and then a particulate bone graft is subsequently passed through the crestal window to elevate the Schneider membrane. The advantage of this technique combines direct visualization of the membrane with the minimum flap reflection. فهي الطريقة هي بتعطي direct visualization and manipulation للممbrane. After reflecting the full thickness of flap, نلاحظ and they did the window, and then they use the piezo and the hand cement to push up the membrane with the attached alveolar bone, and then they packed the area with the bone graft and covered the area with the membrane, and then reflect the flap and switch to the flap. This is one of my cases I did when I was resident at University of Maryland. طبعا مثل ما ملاحظين هون عندي ال alveolar bone height between 2 to 3 millimeter. This is a case of lateral window. But as you can see here, نلاحظ احنا في عنا هون radio opaque dot on lateral wall. This is the artery. This is what we talked about at the beginning of this lecture. This is the intraosseous branch of the posterior superior artery. ومثل ما ملاحظ location على artery is immediately into my window. So in order to avoid the possibility of the bleeding issue, I approach with a Crestal sinus lift. And this is a preoperative clinical photo. ملاحظ عنا remaining root للmolar and 2 premolar, and missing the first molar. This is number 12, 13, missing 14, and then remaining root number 15. So after I did full thickness of flap, I used piezo to outline the window crystally, and then I used acetone here and to elevate the bone block and the membrane. So very gentle tapping with a white acetone. I tapped the bone block into the sinus, and here, as you can see now, the bone block is completely moved into the sinus. هلا the advantage of this technique طبعا أنا عندي صار هون autogenous bone وعندي 4 wall contained defect with a very good blood supply للبون graft. فأنا هلا ممكن لما أحط البون graft تبعي عندي well contained defect وعندي good blood supply. وهون مثل ما شايفين I packed everything with the FDBA. حتى remaining socket after I did the extraction, I did like socket preservation on the adjacent teeth, and I covered everything with a membrane and suture the flap. It's very important with such cases to have a primary closer. طبعا لازم يكون كمان very selective in our cases. هلا حفرجيكم الكومبليكيشن اللي ممكن تصير بهالتكنيك. هلا هي الاكس راي taken initially. فمنلاحظ الامount of the remaining average bone height، وهلا منلاحظ الامount of the bone gain after this technique. And this is 6 months post operative. فمنلاحظ هلا هون صار عنا حوالي 9 ملم، كان عنا حوالي 2 3 صار عنا 9 ملم. طبعا انا بالكيس ما كان بدي اعمل elevation اكثر من 5 6 ملم خوفا من انه يصير عندي perforation. And this is just to show the the bone gain that we achieved. So preoperative we had 2.8 millimeter, and postoperative we had 7.75 millimeter. So it's about 5 millimeter bone gain. And this is 6 months re-entry. So as we can see, we have well-formed dense bone, and this is the implant placement. فبنلاحظ احنا طبعا احنا الامبلانت اللي استخدمته طوله 10 مللي، فاضطريت اعمل الvertical osteotome just to make sure that the implant is completely surrounded or covered by alveolar bone, by the bone graft. طبعا انا كمان بالاوستيوم حسنت اعرف الدنسيتي للبون to make sure that there is no fracture بالبون بلوك اللي رفعته، وبالتالي فعلا كان عطت نتيجة جيدة. And this is a parameter X-ray. As we can see here, this is a amount of the bone gain and completely cover the implant. On the other side, I did external sinus lift. As we see يعني نحن بنشوف هلا الصورة بنحب نشوف البون جرافت كيف هو reaching the anterior wall, the sinus. And this is the stage 2. طبعا هون عملنا stage 2. بعمل apical position flap to shift the keratinized tissue from the crestal aspect to the buccal aspect of the implant. So I have good keratinized tissue surrounding the implant. And this is to show implant temporization and loading. We can see the temporary, and we see the stability of the alveolar crest surrounding the implant. وحتى بنلاحظ إنه البون surrounding the implant apical part. هلا خلينا نشوف الكومبليكيشن لهيك حالات. طبعا هي حالة كمان أنا سويتها بنفس التكنيك، لكن صارت معنا complication. Patient came back with a huge oral enteral communication, as we can see here. طبعا patient كان diabetic, كان smoking, but he claimed that everything is under control, well, diabetic and under control. So we want to make sure that we have very good selection للcases. طبعا هندير بالنا ما يكون المريض مدخن، ما يكون مريض سكري بهيك حالات، لأنه مثل ما شايفين it's very big complication. طبعا احنا we could manage this complication. We raise full thickness of flap, and we debride everything. It was completely infected side. There was bone necrosis مثل ما شايفين على الأشعة هون. This is the infected bone grafts, and this is after we clean the area. نلاحظ صار في عنا some necrosis on the alveolar bone. We cleaned everything with a saline, and then we covered the defect with a non-resorbable membrane, and then we covered the non-resorbable membrane with like collagen membrane, just to make sure that we have a good soft tissue healing. And this is a primary closer again, and this is 3 months after managing this complication. So we achieved soft tissue coverage, closing of the oral enteral communication. فبالنهاية this is what I like to share with you. If you have more than enough for yourself, build a bigger table, not a higher wall. طبعا بالنهاية أود أن أشكركم، وإن شاء الله نلتقي بمرات قادمة. إذا حدا عنده أي سؤال أي استفسار, you are welcome to send me email or call me. This is my contact information. Also, you are welcome to visit my Facebook page. There are many clinical cases, so you can also take a look to these cases. وإن شاء الله نلتقي على خير قريبا، والسلام عليكم ورحمة الله وبركاته.